Good afternoon, everyone. My name is Stephanie Romano, and I'm the Education Coordinator with the Base Hospital. Thanks for joining us for another webinar. Today we're talking about crush syndrome in the field. Oh, actually, I forgot to start the broadcast. So we're going to do that again.
Now starting. All attendees are in listen-only mode.
Good afternoon, everyone. My name is Stephanie Romano, and I'm the Education Coordinator with the Base Hospital here in London. Thanks for joining us for another webinar presentation. Today we'll be talking about crush syndrome in the field. If it's your first time joining us for a webinar, you'll see a control panel and a PowerPoint presentation. In your control panel, you have a couple options. You can ask questions throughout the presentation by clicking on the chat box or the question box at the bottom of your control panel. So you do have the opportunity throughout the presentation to type questions to us. Those questions will go directly to the panel, and then they will answer those questions live to benefit the rest of the audience. If you do have a microphone and you'd like to ask a question live, you have the option to raise your hand. So there's a hand icon that you can press. We'll see that you've raised your hand, and then we can unmute you. And so I will introduce our panel today. We have Wade Diamond, who's a CCP at Orange. We have Dr. Randy Wax, who's a critical care physician at Lakeridge Health, who's also a transport physician and medical director at Orange. We have Dr. Mike Llewell, who's the regional medical director here at SWORBHP. We've got Drew Shapert, who is our EMS fellow at SWORBHP. And we've got Marcus Van Arsen as a resident at LHSC. And so with that, I will hand it over to Randy, who will start the presentation.
Good afternoon, everybody. It's Randy Wax here, and my good friend and colleague Wade Diamond is here as well. Wade, are you able to speak as well?
I am. Can you hear me okay?
Perfect. There we go.
Great.
So that's great. So Wade and I are going to be presenting this in a tag team fashion. We both worked together on this call with Orange. Wade was on scene with his partner Tara, and so I think we're going to be going back and forth. If there's questions that pop up, we've had our Twitter handles and hashtags and all of that when we did our presentation at the Ontario Paramedics Association conference, but fortunately today we'll use a different system for forwarding questions as needed. And I'm going to hand it over actually to Wade to give an introduction to this call. And the plan is we're really going to try to give you a description up front about the call and what happened. And we're going to be going back and forth talking about different aspects of management and thinking a little bit about what lessons we learned from this, both clinically and from a systems perspective. So Wade, why don't I hand it over to you so you can get started. And Wade, just let me know if you want me when to advance a slide, and I'll just move it forward.
That's great. Thanks, Randy. I've got that first slide with the photograph up, and that's just fine right now. So welcome, everybody. We did do this presentation at the OPA conference. It's a very interesting case which involves some rather complex logistics as well as very complex physiology and trauma physiology, and it goes across quite a breadth of different issues. So hopefully there will be a lot to glean from this for you guys. I know there was for us as well. And this photograph that comes up first is one of myself and my many colleagues from Hamilton Fire, Hamilton EMS, Halton EMS as well. As a variety of other agencies that came together on this rescue on this particular day last summer. It's quite a powerful picture, and I think it tells a lot about how everybody came together, and we'll talk about how everybody worked together towards the end of this. But if we just give you a bit of an outline of what this call was, if Randy, if you could move the next slide, please. What happened in this particular call was we were launched on the helicopter from Toronto Island at around 10:56 a.m. This is just a couple of things about this day. It is probably 40 degrees with the humidex on this particular day, and a very warm summer morning. We're notified that we are launched to an area where what was described as a concrete block had fallen on an individual. So at this point in time, of course, we're responding to the call. We're kind of running through a few things in our minds. We're like, oh, what kind of a concrete block is, it's a very big difference between a cinder block and something much larger, and there's anything in between. So we started running through a few of these thoughts in our mind with very little information. We know that the PCP PRU arrived on scene at 11:10 that morning. We were launched actually quite a fair bit afterwards. We weren't double dispatched, which would have been ideal in this case to get us there a little sooner. However, the first PCP, one of our colleagues in Hamilton, on the scene identified the need for a lot of different resources, and she activated all of those, including ourselves. We're told that they're going to an area that's rather rural, and we do land on the scene and find this rural area. It's along a small river. And so you can kind of picture, and we have some pictures a little bit in a minute here to show you that'll help out with your visual of it. And this area is just below a dam and underneath like a train trestle. There is apparently a structural wall collapse, and we find out when we arrive that there is a large concrete slab that we estimate there was about 50,000 pounds that had landed on this patient's legs. It separated, and I'll show you how that happened in just a second, and had landed on him, and he was entrapped there. Extrication had begun, or attempts at extrication had begun, but so far there wasn't much success at this point in time. I'll talk about that in a second. As we were preparing for this scene, and I know one of the things that we're going to come around to here at the end is specifically stuff directed at different levels of care and at your own level of care, so bear with me as we talk about it from our perspective, and we will come together with some really good points for everybody at every level of care. When we were arriving on the scene, we were thinking again, well, okay, this question is how this object is going to impact this individual, and whether we're going to have, we have hemorrhage control, do we have a crush syndrome? That was certainly something up front that we were thinking about. We prepared all of our equipment as we arrived, and we had to land just in a field just adjacent to the scene, so it took a little bit of actual physical movement to get over to the scene. Could I get the next slide there, please, Randy? Thank you. So this is what we're confronted with, and the immenseness of this object is obviously not lost on you now that you see the photograph, and just if you look at the photograph on the left-hand side, you can see that the height of this object is probably close to a little over a story tall, and it's about the same width across. It's about 1 foot thick, and it is laying resting right on top of this patient's legs, about mid-thigh or so on both legs, and he is trapped under there. EMS first medics on scene have done all of the standard stuff. It was totally appropriate, and they have given, they have started IV fluids, they've administered oxygen. There's not much room for adding warmth to this individual because the heat baking down there, actually the temperature was just almost unbearable. They have also administered about 10 milligrams of morphine at this point in time to try and alleviate some of the excruciating pain that this gentleman is in. You can also see some of the access issues there. You can see that there is this riverbed and this water that we have to hike through, and it's quite difficult to traverse just the rocky shoreline as well. There was many times where all of us were catching each other as we stumbled and fell as we tried to wander around this scene and get our work done. I mentioned already about the time, or sorry, about the temperature, as well. The time frame, if we just go back to, I mentioned that notification time was 10:56. The flight crew now is on scene. This is about 11:48. Okay. The egress is also very difficult as well. The egress is going to be through this rocky shoreline and up a steel staircase, about 3 or 4 flights of stairs. So if I could get to the next slide there, Randy, the one past there. Yep, next one there. Thank you very much. Back there you go. So our initial assessment, as I described to you already, was that we have this male who is trapped under this, both legs trapped and crushed under this slab. His GCS is 15, and his initial vital signs, his heart rate's 140, His blood pressure, initially it's not written down here, but his blood pressure he was fairly hypertensive. Actually, he was 140 to 150 systolic on our initial assessment. Respiratory rate of 32, and he was satting really well at 100%. You know, the rest of his examination really revealed no other major sites of injury. This was all isolated to the lower limbs. He was a sinus tach on the monitor, and I already had mentioned a little bit about some of the treatments that have been given so far. If we could get the next slide there, please, Randy. Thanks. So at this point in time, of course, what are we looking at? Our immediate concerns, of course, is rescue, getting him out of there. So just a minute, a word about that. So what had happened at this point in time was attempts to put the airbags under, which are supposed to lift, be able to lift this. I believe it's one airbag typically that can lift about 25,000 pounds. And so with the two of them, they should have been able to get this up. But what happened was the ground around it was so loose that couldn't actually, fire rescue couldn't actually get the bags to stay stable enough to get some cribbing underneath there and hold it. There was a big concern that there would be a secondary secondary fall of this or collapse of this object, and obviously this could impact a lot of people. So there's a lot of concerns about safety of everyone at the scene. We were thinking about the patient, of course, beyond the rescue component, because we had lots of people working on that. Our issues were around stabilizing this patient and thinking ahead about how we're going to deal with the release. And we're going to talk about what happens in crush syndrome and what can happen also when you release such a large object for someone. And of course the extrication is mentioned here as well. Our primary problem list when we assessed this individual was hemorrhagic shock. We got to think about that first. We have tachycardia. We have the mechanism that makes sense. We can't physically examine the blood loss. We simply can't see behind the object to see what the volume loss is. But we'll talk a minute about what we can assume the losses would be when Randy is making his points made a little bit here. We're also thinking crush syndrome, and that was pretty much right off the bat when we see it. I remember looking at my partner as she was picking up the phone to talk to Dr. Wax here, and I saying, you know, this is a true crush syndrome, and we're going to have to go down that road. It's going to take a very specific path. Long bone fractures, of course, and a big part of this is pain. Obviously a very significant amount of pain and stress for this individual, anxiety, etc. Some of the other concerns that are in our minds at this time and should be in yours if you were in this situation is secondary medical events. When we look at traumatic injuries, the onset of stress-induced cardiac events, etc., asthma, exacerbation, COPD, things like that. We're also thinking, well, this patient's going to get a lot of volume. What about the possibility of them having volume overload? Are they going to end up in CHF and pulmonary edema? So there's a lot of things we're watching for and thinking about at this point in time. Could I switch to the next one there, Randy, please? So what else happened here? So as we said, we mentioned we arrived at 11:48, and although the patient's had some analgesic, he's in excruciating pain. So we initiated analgesic management with ketamine, 25 milligram IV boluses, plus 50 mic boluses of fentanyl, Q10 minutes. So we're going quite aggressive with the analgesic. The nice thing about, we'll talk about ketamine a little bit later, but ketamine is a great drug for this in that it can cause nice dissociation and it can reduce stress for this individual. It can help with analgesic, and when you do it, when you're using the two drugs together, you have the beauty of synergy. And synergy is good and synergy can be bad, but in this particular case it was working to our benefit. Still really hard to get a good bite on this patient's pain for certain. The other thing that we did at this point in time was we applied the CAT, so the combat tourniquet. We had those available. We carry them in orange. You may use something like that or something similar. We'll talk about them further. We applied it to the right thigh. We were unable to get it onto the left thigh just because it was inaccessible to wrap the object around. Now, our concept behind this is a pre-release technique, and we'll talk about it further, but our thought was, well, we have an issue of potential release and uncontrolled hemorrhage, as well as the release of all of the nasty stuff that builds up in crushed limbs. Randy's going to explain that at length. We have the ability, of course, to administer some other medications that are very valuable in this syndrome. We started bicarbonate. We gave a slow push and follow that up with some infusions. We also gave a gram of calcium gluconate as well, and for cardioprotection for the hyperkalemia that associated with rhabdomyolysis. We also gave 1 gram of TXA. Randy's going to talk about TXA. It's a drug that's we've been using for quite some time, but I believe and hopefully it's something that we see rather widely spread around the province, and I expect you'll hear a lot more about that in the future. Thanks, Randy. Next slide here, 12:30. What we have arrived on site is the Hamilton General Hospital Trauma Team, site team. And they were called in for the possibility that we're just not going to get this object off of this patient, and that there may be the possibility of a site amputation. Very rare. I've only personally come across these a few times, or a few potential times in my career. You may never see one in your career, or you may see one tomorrow, I don't know. But it is it's a very big deal, and it requires a lot of organization. When the site team arrived, we had Dr. Niv Snee, who is, if you know him from Hamilton General, a fantastic trauma team leader and physician. And, him and his team, they arrived with their surgical items, and at the same time, we had the arrival of our blood products and additional bicarbonate. Logistically, this is a big deal. To do that, we have to go through a lot of steps, and I've got another slide further where I'm going to expand upon how that works. We initiated a packed red blood cell transfusion, the first unit, as soon as that arrived, and then we also started, as I mentioned, this bicarbonate infusion. Bicarbonate infusion is 2 amps in a liter. Thanks, Randy. Next one's fine. Yeah, thanks. Follow this up. We followed up as extrication is ongoing. The second and third units of packed cells are infusing, and at this point in time, because we can't really get this good tourniquet around, the surgical site team decides to grab surgical control of the left femoral artery, by which they do a cut down and clamp the femoral artery so that we don't have a loss when the release occurs, blood loss when the release occurs. Next one, please, Randy. So here we are at this point in time. That's been done. A lot of painful procedures, a lot of things going on, and we have a discussion with the site team as well as obviously Dr. Wax about the need for airway control in this patient. Now, at CCP level and the ACP level, we have ACP flight level. We have a variety of different options for doing this, and in this particular case, I'll talk about this for a little bit here. So in this particular case, we did have an option for a rapid sequence intubation. Typically, we don't use paralytics in the pre-hospital environment. However, in extenuating circumstances such as this one, it was an option available to us. Instead, what we did, and the way that I worked through this, was looked at all my options, and the way that the patient was positioned, essentially in my arms and leaning backwards. I simply couldn't get him to lay completely supine. It was impossible for the pain. What we tried to do was increase his sedation and analgesic as much as possible, and to see if he would release well enough for us to get a good view. The problem with administering a paralytic in this particular case was that I really had suboptimal conditions. Everything about this was a bad place to be trying to manage an airway with a paralytic on board. We had it available should we need to administer it post-intubation, or should we get in a situation where we were getting a decent view but we could enhance that view and use the paralytic. So We held back on that and instead went with the approach, as I say, of ketamine. We used lots of topical lidocaine, which is a great drug which we always have to remember as a good option for improving intubation pre-hospitally. And in this particular case, as I say, we used we had already given quite a bit of fentanyl as well. There was a little bit of Versed on board, so we had this nice synergy between these three different drugs. And what eventually happened was, if I could get the next slide, please, Randy. We went ahead and did was a blind nasal tracheal intubation. Now, in different base hospitals, you may have different rules around this. It may be permitted, it may not be permitted. I'll speak to it as a proponent of it as being a forgotten and yet very valuable emergency airway technique. The blind nasal tracheal intubation was something that, not too many years ago, we used it a lot, and people have gotten away with it. There certainly are some issues with it. There are some contraindications to it. However, when it's done properly and appropriately, it's a very useful tool. So in this particular case, because we had a nice sedation, what I did was put capnograph on the end. So pretty much everybody who is in an ACP is going to have the ability to use a capnograph. And when you apply the capnograph to the end, not the color metric, but an actual capnograph, and put it onto your monitor, as the tube is advancing back into the hypopharynx, and you'll start to see, especially for the, obviously for the breathing patient, you'll start to see a capnograph waveform. That helps to direct you a little bit. And if you're using the an endotrawl where you have a trigger where you can pull and angle the distal end of the tube up and try and get it in through the cords blindly, that can help you as well. What you'll find is there's a couple of areas of this, and I know we're going to try and discuss this because at the OPA conference we actually had stations, and clearly we don't have stations here, so I'd like to just describe to you a couple of the sort of pearls and pitfalls to doing this skill. One of them is, as I say, is to watch that, to remember that just because you get a capnograph, a nice waveform, you may still be in the hypopharynx. So that tube has to be pretty much buried right up to the end, into the to the end at the end of the nair. And you'll want to do that so that you ensure that you're actually endotracheal as opposed to in the hypopharynx. That's one thing. One of the other things is when you insert the tube into the nair, remembering the the anatomy and knowing that the key is to go essentially just slightly angled up, but pretty much going straight back and being very gentle and deliberate about the process. Certainly making sure that the tube is lubricated and that you add Otravin topically, as well as some lidocaine in intranasal as well. And it's a very good way of intubating patients. It's I find it very successful. You can use it with or without sedation, depending on what your patient's like. What I find it great for is so many patients that if they're not paralyzed, they either have a trismus or they're just too tight around the mouth so that you can't actually insert a blade and get a good view. So that's my thoughts on that. If we can move forward to the next slide, please, Randy. Randy? Thank you. So next one here we go. Just a little bit of follow-up as to how the rest of this call played out. The patient has been intubated, and we did administer some rocuronium for paralysis to improve ventilation and oxygenation as well. And at 13:22, we had successful extrication of the patient. We started moving towards the helicopter and were airborne around 13:40. Myself, my partner, the patient obviously, and Dr. Snee on board, where we had pushed an additional couple of amps of bicarb and another gram of calcium gluconate. And in the next slide, we'll show you some how the patient was looking here. So this is en route to Hamilton General Hospital, and we have everything set up to the point, right down to the point where they actually are ready for us in the OR and know exactly what trays they want to have out because of the communication through Dr. Wax. So everything is set, and what we find on our patient here is that hemodynamically is done well. We've had a couple of small blood pressure dips, but not too bad. They've remained relatively normotensive. In fact, in this particular one, I believe the blood pressure was, I don't know if I can actually see it on that one, but it was somewhere in the 110 to 120 systolic range, quite decent. We look at the ECG here, and Randy will explain a little bit about why this happens, but of course in the case of rhabdomyolysis, crush syndrome, we end up with hyperkalemia, and hyperkalemia is typically identified on the ECG by widening of the QRS and elevation or spiking of the T waves. So there's the question here, I guess, if you look at that and say, well, is it widened? Are the T waves greater than 50% the height of the R wave? And I guess the answer really here is they're not quite there yet, but they sure look like they're on their way. So the interesting thing is you wonder how much more severe this would have been had the measures we had performed not occurred. And Randy will talk about that at length. If we look at the rest of the vital signs, some of the other issues we had in flight, we did have one drop in the saturations, and we have been able to recover that. To recover that, we increased the PEEP, so the positive end expiratory pressure on the. In this particular case, we didn't have him on the ventilator yet. We had him on just a bag and mask with a PEEP valve, or a bag and endotracheal tube with a PEEP valve. And by increasing that PEEP, we were able to, and doing appropriate ventilatory strategies, we were able to increase the SATs up into the 90s. As I mentioned, the heart rate's been very tachycardic throughout. It really fits the whole picture here with this patient. And one of the other nice things here about end-tidal CO2, I love capnograph, and end-tidal CO2 is a great thing. And look in this particular case, and we say, okay, well, we do have end-tidals of 23. Good indication that we've got some decent perfusion, highly suggestive that we've appropriately transfused and maintained decent oxygen transporting capabilities within his circulating volume. Next slide, Randy. I think that might be the end of my section here. Oh, no, sorry. I guess this is my own little self-promotion thing here, because one of the thoughts I did have as I mentioned about the drop in the SpO2 was some of the different possibilities. Earlier I had mentioned their concern that this gentleman may end up with pulmonary edema simply from the large volumes of fluid. When you look at the amount of time that this individual from the time of incident or injury until the time we're actually transporting, looking at a good couple of hours or so, one of the things that can start to develop is acute respiratory distress syndrome, and I just happened to have written an article a few years ago based on a case where we pretty much had an onset of ARDS in the pre-hospital environment and near drowning. So it was certainly one of the ways that we were addressing the oxygenation issues was we were treating it as though it may be a early onset ARDS, and that's what we went to with our ventilation strategies with this particular case. And Randy, I think I get to hand it off to you.
Yeah, I think I'm taking over here.
Very good.
Just hang on one sec, guys. I'm getting a little echo. Just got to change my audio here just for 1 sec. So just want to talk a little bit about crush syndrome and rhabdomyolysis and how this fits in. And I don't want to get into a lot of deep physiology, but clearly you've got a number of reasons why soft tissue muscles are going to be damaged. Direct injury to the muscles results in rupture of the cells and release of various compounds, creatine phosphokinase, myoglobin, and other toxins. Particularly things like myoglobin can end up causing nephrotoxic effect to the kidneys. So one of the common things that we worry about in these patients is actually development of renal failure. And certainly in a situation like an earthquake with multiple casualties, one of the big stresses on the healthcare system for patients who survive crush injuries is actually trying to be able to provide them all with dialysis. But fortunately in this case it was only one patient. Due to shock, globally, and also due to local ischemia because of impaired perfusion, because of vascular compression, you get lactic acidosis, and so buildup of lactic acid locally in the tissues that are affected. Now, if you've got a huge slab of concrete basically blocking perfusion of the leg, a lot of that lactic acid is going to build up within the limb that's affected. And so, you know, we'll come back to the whole issue about what happens when you release the compression. But the concern is that in that local area of the body, you've got a huge buildup of lactic acid that can suddenly flood into the circulation as soon as the patient is getting extricated. You get changes in terms of sodium and calcium going into cells, which can cause systemic problems like hyponatremia and hypocalcemia. But more important and more dangerous is you can actually get release of potassium out of the damaged tissues into the blood, and that can cause hyperkalemia, and if severe enough, that can lead to a cardiac arrest. We also worry about compartment syndrome. So if you remember, in the extremities, there's different compartments that are bound by connective tissue, and if you get swelling within a compartment and the pressure gets too high, if that pressure gets greater than perfusion pressure, you get ischemia of those tissues as well. And so the big picture is you have worsening shock systemically, worsening acidosis, which can all lead to multiple organ failure, cardiac arrest, and death. So crush syndrome is definitely a bad thing. So really our biggest concern in these patients is the death on extrication. Now, I wasn't on scene, Wade was, but he was talking to this patient who was awake certainly earlier on before he got heavily sedated and then intubated. And these are potentially very sad stories because you come and the patient's in pain, but they're awake and talking, and you certainly will hear stories of these patients who are awake enough to be able to get on their cell phone and talk to their spouse or their children, and they're awake enough, and then unfortunately if things go not so well on extrication, these patients suddenly die. This typically happens during release of whatever it is that's compressing the extremities. The most dangerous thing you get are the dysrhythmias from the hyperkalemia. And the first hour after release of whatever's compressing the tissue, you're at risk of significant increases in your potassium level. You can get the third spacing of fluid, so in damaged tissue you get a lot of capillary leakage and fluid leakage, and in order to maintain systemic perfusion you've got to give fluids. So there's a maldistribution of fluids even as you try to resuscitate them, it's going in the wrong place. And during all of this, you're getting release of toxic compounds from the damaged tissue that can lead to a reperfusion injury systemically. So you're getting release of all these toxic compounds that can deposit in kidneys and lungs and other tissues and lead to multi-organ failure. You can get respiratory failure, particularly, as Wade mentioned, due to pulmonary edema from large crystalloid resuscitation. And just the toxic compounds released in the blood can cause inflammatory injury to the lung, and you can get full-blown acute respiratory distress syndrome and difficulty ventilating these patients. As well with long bone fractures, you can get fat emboli that can also cause problems in the lungs and other tissues as well. These patients can have a significant activation of the coagulation system, so you can get what's called disseminated intravascular coagulation. So you basically get clotting that's happening in all the wrong places at a microvascular level, and the fibrin strands will destroy your red blood cells. So in addition to your bleeding, you actually get intravascular destruction of your red cells. You also use up all your clotting factors again in the wrong places. You become coagulopathic, so you're clotting in places where you don't want to clot, doesn't leave you enough clotting factors, and you continue to bleed through damaged tissue. Your platelets can also be bound up in these clots in the vascular space, so you can get thrombocytopenia, and you're also using the platelets to try to clot to prevent further bleeding, so you can consume your platelets very quickly, so you can run into further bleeding issues related to low platelets. And as well, if you get shock liver due to hypoperfusion, your liver stops making some of your coagulation factors, so you can have ongoing coagulopathy as a result of shock liver. Later, these patients are definitely at risk for infection, so certainly antibiotics for open fractures, decontamination of the wounds, very important as sort of an early intervention for these patients. And then again, we worry about the compartment syndrome depending on how much edema is occurring within the compartments and the limbs that are affected. So for acute renal failure, there's multiple reasons: the shock, hypovolemia, release of myoglobin, acidosis, and gumming up of the renal tubules with all these toxic compounds certainly really, put these patients at risk for acute renal failure, and that's, as I mentioned, a big problem in these patients later. So just coming back to sort of our pre-hospital management for these patients. So we're really concerned about the potential for hyperkalemia and death. And so while they're trapped, and certainly during extrication, it's extremely important that we have continuous cardiac monitoring. You're going to go ahead and support with oxygenation, partially because of the risk of lung injury, and often these patients are so shocky it's actually difficult to reliably check their oxygen saturation. They're so hypoperfused. You often will want to just give supplemental oxygen empirically. These patients are definitely at risk of hypothermia. Now, in the case of this patient, it was actually quite hot, but certainly in other situations where they've got prolonged exposure and bleeding, and especially if you're having to resuscitate with cold IV fluids, you can get hypothermia, and we'll talk about how that fits into badness from a trauma resuscitation standpoint. You're definitely going to want to get IV access or intraosseous access, depending on which limb is available to you for IO access. You could look at potentially accessing for an IO, and you definitely want good vascular access for fluid resuscitation, your various meds that you need of blood products. Good analgesia and sedation, and we talked about that. Now, bicarbonate is good for a couple of reasons. Bicarbonate is helpful as one of the ways for treating hyperkalemia. So if you are acidotic and you give bicarb, that change in pH actually forces potassium back into cells and actually shifts the potassium, and so that's a good treatment for that. As well, bicarbonate may be more effective than other fluids for protecting the kidneys from the damage from crush injury, from myoglobin and other things. So certainly any fluids is better than no fluids, but if you have a choice, there's some literature suggesting that bicarbonate may be a good option, and because you get the double benefit of treating the hyperkalemia and maybe protecting the kidneys, it's definitely something to think about if you've got it available. Calcium's also important. Calcium is cardioprotective from hyperkalemia. In fact, if you're seeing the ECG changes from hyperkalemia, the calcium is the first thing you're going to want to give, and you can actually see on the monitor right away if you're getting these widening QRS complexes. As soon as you give calcium, within 10, 20, 30 seconds as the calcium starts to circulate, you start seeing that QRS come back down to normal. So it's extremely important. As well, if the patient's bleeding, especially if you've been giving blood along with it, you can get hypocalcemia, which can contribute to bleeding, and so you get the added benefit of the calcium of potentially reducing ongoing bleeding if you're treating with blood. We'll talk about that more in a bit. You want to treat hypovolemia, and Wade can certainly talk about the need during all of this for an awake patient who's trapped and who is at significant risk of dying, the emotional support that you need to provide to this patient who's in a very awful situation. So we want to stop the cell injury. So ideally, if you can extricate and try to preserve the tissues, that's ideal. We want to stop bleeding and also try to prevent, if we can, the release of toxins, especially during extrication. So Wade's going to talk a little bit more about the use of tourniquets, but in general, the idea is that if you can put a tourniquet on, if you've got a bleeding source that you can't control otherwise, you can potentially reduce the loss of blood from the limbs that are trapped. But also, when you do extricate, it helps prevent some of the toxic soup from the damaged tissues from coming back into the patient. So that can be helpful. You want to give titrated volume replacement. So just like any trauma patient, you want to be careful to give enough fluids just to try to get a minimum systolic pressure of about 80 or 90, or if you're having trouble measuring a blood pressure, a palpable radial pulse, and ideally a patient who's conscious. You don't want to over-resuscitate with crystalloids then, because you're going to make the patient hypothermic, you're going to dilute the coagulation factors and the hemoglobin that they have, and you may actually worsen bleeding by preventing clot formation by making the patient more or having a better blood pressure than they really need. You'll look at giving the bicarbonate, and the way we usually did that, you can't push amps of bicarbonate directly, although often what we'll use for fluid resuscitation, if you take a liter bag of D5W, you can take out 150 cc's and replace that fluid you took out with 3 amps of bicarbonate, and that makes basically a fluid solution that's essentially isotonic. It's like normal saline, but instead of a chloride, which reduces your pH, and actually you replace that with bicarb, which helps with the acidosis and it can be protective. And I mentioned the calcium already. And whether you use calcium chloride or calcium gluconate, the two forms of IV calcium, to be honest, doesn't really matter. Whatever you have readily available and use, just use it. Calcium chloride is usually the one that's in the pre-filled amps. So if you have sort of typical ACLS drug situation, usually it's calcium chloride that's going to be available to use. And in this situation, you use whatever calcium you need. And so the key thing for protecting patients is that whole issue about hyperkalemia. So to summarize, what we typically do, in an ideal world, if you're hyperkalemic, what you want to do is get rid of the potassium. So the way we typically think of doing that traditionally is giving, for example, K-exalate. So you take that orally, it binds the calcium, and then you basically poop it out. Unfortunately, in this kind of situation, that's a completely impractical way of treating potassium, so that's not useful. If you give a diuretic, you can pee out the potassium, but if you're already hypovolemic, that's not such a good idea. If the guy's in a hospital, you can do dialysis. So these are all things that we think about getting rid of this. But these are not really sort of the key options. So what you end up doing initially, you may not be able to get rid of the potassium, but what you can do is actually try to temporarily shift the potassium into cells to try to reduce the hyperkalemia. The problem is that that's not going to get rid of the potassium. That's just going to temporarily deal with it. So eventually you still need to make sure you've got good renal perfusion and able to pee out the potassium eventually. But sort of the mainstay treatments for shifting potassium into cells, insulin and dextrose. So insulin will actually drive the potassium into cells. And if you give glucose, the idea behind the glucose is to basically balance out the treatment with the insulin to prevent hypoglycemia. You sometimes will, if you just give dextrose and you get the patient's own insulin release coming in, you can sometimes get a little bit of shift potassium just by giving the glucose, but typically you give it with the IV insulin along with it if that's available. Ventolin as a beta agonist will actually help shift the potassium into cells as well. Epinephrine has a similar effect, whether it's done IV or IM. Epinephrine can potentially move it into cells, and as well bicarbonate, as we mentioned, can treat acidosis and help move the potassium into cells as well. So I'm going to stop there right now, and I'm going to hand it over to Wade for the next part of this.
Right, okay, thanks Randy. So, and this particular slide I bring up the question, is it crush syndrome? So I think one of the first things that all medics have to think about when they're looking at someone who is in a potential case where there might be a crush syndrome is you really have to truly evaluate it, because the interventions to treat crush syndrome when used when crush syndrome is not present, those interventions can be negative. And so this happens to be a photograph of a case I had not too long ago. It just came to mind, which was of an individual who was entrapped and certainly pinned but not crushed. So we do have to evaluate that quite carefully when we're thinking about managing a patient as though they are a crush syndrome. I'd like to bring to your attention to the idea that crush syndrome and not just crush syndrome, but associated with that rhabdomyolysis, which we're talking about here, is exactly what we're talking about, is present in a lot of other situations that you all as medics in the field will run into on a rather regular basis. And you do have to be kind of aware of looking for it for your to be able to catch it and to be very cognizant of its possible presence. So some of the cases that you might find, I'll give you some examples, would be the individual where you get the call for elderly male has been not seen for a day or two, has been at home, and what has happened is he's had a slip and fall and he's been just in his bathroom laying on his side for the entire time since his slip and fall. So for that period of time you end up with exactly the same thing. You end up with this compression going on in the large muscle groups where you end up with exactly all the things that Randy's just talked about. I don't need to explain it any further. He's already explained it. And you end up with this rhabdomyolysis. I'll give you an example of one that always stands out in mind for myself. Was one, this was very early in my career, and it just stands out to me very strongly, was for a gentleman in exactly that situation, elderly male, found by his nursing care worker, had not been seen since the day previous, and had said around midnight he had fallen or slipped off of his bed, and he was, if I can try and describe this to you, laying with his lower legs folded underneath him and backwards on top of him. So imagine what a painful situation that is, but he simply couldn't get up. When we tried to straighten his legs, they are extremely tense. It's a classic finding of this syndrome. So one of the things I'll always remember is exactly how hard it was to just get him extricated from the floor, as it was, and to get him straightened out. This is the case where you're looking at the exact same thing going on, and this individual is at high risk for developing arrhythmias. You have to be on top of it, and you may be thinking about it, depending on your level of care, as to what we'll talk about different levels of care in a minute as to what you could be doing, but you might be thinking about calling your medical direction and getting some orders for some of these different things that might be available to you. Another classic example will be Etoh substance abuse, a patient who is again found unresponsive, laying on the ground, may have had a medical event, but has been laying there for quite some time. As I've mentioned here, anything with prolonged immobility, look at it. If we could get the next slide there, Randy, I've put up some of the hidden signs or some of the clinical findings. So again, it might be rather benign. You really have to be looking for it, but you have to be suspicious based on some of that historical information. Pain, of course, bruising, erythema, and diffuse edema to the limbs involved, skin breakdown, just like you see with pressure sores, and the tense limbs as well. These might be all findings that you may encounter. Thanks. So tourniquet use. Tourniquets are awesome. It's decided, right? The evidence is there. Tourniquets are awesome in uncontrolled hemorrhage. When we talk about them in crush syndrome, I agree with Randy in that this was totally this was the way we should go in this particular case, to try and, as he refers to, reduce the risk of just that flooding of the toxic soup from those limbs, and that's exactly what we did in this particular case. Once we were able to access the other limb, it had already been, as I mentioned, there had been a cut down and control of the femoral artery was done, but we added a tourniquet above that as well. As soon as we had access to it. And I think despite the fact that there is no literature that really strongly says, hey, this is absolutely what should be done, and in fact in some places currently they're saying we don't recommend it as the go-to for every single crush. I think given this case we did elect to do it, and my suspicion is anecdotally that it may have improved our patient's outcome. But as I say, just to give you the truth of the matter is right now there's not the supportive evidence out there that would say that it's an absolute essential. But I think Randy and I agree that it's probably appropriate in most cases when available. The other issue with this particular case was that this issue of hemorrhage, we really didn't know what was going to happen with blood loss when the extrication occurred. So having those in place, whether you tighten them or not, whether you even wait, but they're in place, ready to crank them up as soon as the extrication and the release starts to occur, should there be hemorrhage, that might be another option for you, depending on what your situation is. So having them in place might be another thing to think about, even if you're not going to actually apply the pressure to them. We'll talk about tourniquets again shortly here. I think there's another slide coming up. I got the next one there, please, Randy. Right, so I'm going to give it over to Randy, I guess, now, and I'll be back shortly.
Great, so I'm just going to talk about hemorrhage for a little bit and management. So one of the things that's key, people typically throw up this slide for trauma about the triad of death. So metabolic acidosis, coagulopathy, and hypothermia. So just to talk about this for a second, when you have patients who've been bleeding out a lot with trauma, you get a consumptive coagulopathy, so you're using all your clotting factors to stop the bleeding. That's your body's way of preventing exsanguination. As these patients get cold due to exposure or due to fluid resuscitation, as your temperature goes down, your clotting enzymes work less effectively when you're outside of normal body temperature. And so your ability to actually stop the bleeding actually is impaired as you get hypothermic. And as well as you continue to build up metabolic acidosis from shock, from hemorrhagic shock, what happens is that, again, when you get outside your optimal pH range for your clotting enzymes to work, your clotting enzymes don't work so well. So if you get the combination of coagulopathy that's dilutional and consumptive, and hypothermia and metabolic acidosis, these three things, if you don't do something about them or prevent them, will potentially lead to sort of ongoing exsanguination. And you can have a surgical exsanguination from, say, a vessel or damaged tissue, and you can have a medical exsanguination on top of it due to the coagulopathy and the inability for your clotting factors to work. The fourth thing that fits in, so it's really not a triad, it's like a quadrant, I guess, or something, would be adding calcium in the mix as well. It's often forgotten, especially if you're giving blood products. If you're giving packed red cells, the blood would clot in the bag if you didn't have chemicals in the bags to prevent clotting. And things like citrate in those bags will bind calcium as you give them. So the problem is that as you are giving your blood to the patient, you're also going to be binding some of the calcium, making the calcium less effective. So the calcium is important for two reasons. One, most of your clotting factors, or many of them, require calcium as a cofactor to work. So if you're hypocalcemic, it becomes more difficult to clot. And also, you need calcium for your vasomotor tone. So if you're hypocalcemic, you vasodilate, and it can actually make your blood pressure worse. You can get shock not only from hypovolemia or hemorrhagic shock, but also hypocalcemia can be a contributing factor. So you want to prevent or treat all four of these things in somebody who's exsanguinating to prevent inability to resuscitate them. And so just as a reminder, they talk about the different classes of shock, class 1, class 2, class 3, class 4. It's important to remember that even losing up to almost a liter of blood, you may have nothing other than maybe some mild tachycardia before you start, and you may only start seeing some more significant signs when you've lost a liter to 2 liters of blood. So it's really important to realize by the time you're seeing somebody who's really tachycardic, breathing fast, and like significant drop in systolic blood pressure, you're already talking about losing, typically at least 2 liters of blood already before you're actually seeing those signs. So it's important to recognize the potential for hemorrhagic shock early and to try to prevent that if possible. And it's also important to realize in a situation like a crush injury, if you've got limbs that are damaged, you can actually lose a lot of blood in the compartments of your limbs, and it actually can be sometimes subtle. So you can lose 1 to 2 liters in each femur with a femur or each thigh with a femur fracture, and with tib-fib fractures, you can lose up to a liter in each. So if you put two thighs and 2 tibia together, you're talking about anywhere between 3 to 6 liters of blood loss that can occur in those compartments. So you got to be aware that that's a problem. Now, particularly in this patient, you can't even see his legs. So you had no idea whether there was a ton of bleeding going on within the tissues due to crush and damage, or you could have even had a vascular injury where you're potentially losing blood. And as a big concern is when you extricate whatever pressure tamponade you had to prevent ongoing bleeding, you suddenly take away, and these patients can't start to bleed out quickly. And so that's why the application of tourniquets, whether you crank them tight or not, is, I think, a really wise idea, and I agree with Wade, that's a smart thing to do. Key things we're going to do to deal with the hemorrhage, you're going to try to do direct pressure if you can get at it to try to stop the bleeding. The tourniquets are important, immobilization of fractures. In some cases, in some jurisdictions, people look at things like topical hemostatic agents. If you've got ongoing bleeding, you can spray into the wounds to try to stop the bleeding. It's not something we're typically doing in pre-hospital in those places, I believe, in Canada, but certainly the military people have some other options that are available. You want to maintain end-organ perfusion, as I mentioned, target only to about a systolic of 80 or 90. Packed red blood cells are really the fluid of choice in hemorrhagic shock, and tranexamic acid will help prevent breakdown of clot that you've already formed and prevent further bleeding. So key sort of factors in all of this, if you give too much crystalloid, you dilute your hemoglobin, and if you're already bled out, you don't have enough hemoglobin as it is, and now you're diluting it further, so you're making your anemia worse if you give too much crystalloid. If you don't have enough coagulation factors because you've already used them, and now you're diluting them with crystalloid, so that's bad. And then if you actually bring up your blood pressure too much, it's a natural evolutionary thing to get hypotensive when you bleed, because as you bleed and you get less perfusion to your damaged tissues, you start forming clot. If you give them too much crystalloid before you get surgical control of the sites of bleeding and your blood pressure goes up, you pop the clots that are formed and you start actually bleeding more. So a little bit of fluid resuscitation may be appropriate if you're really hypotensive, but too much is actually associated with potentially worsening hemorrhagic shock. As well, the other thing that's important to know is you can develop a non-anion gut metabolic acidosis from crystalloid resuscitation. And again, we already said acidosis is bad. If you've got a lactic acidosis from hypoperfusion, and then you have metabolic acidosis on top from the fluids you're giving, that can be a problem. So you really have to take into account, if you're thinking about crystalloid resuscitation, the transport time. If you've got a short transport in an urban setting, you may not necessarily need to give much in the way of fluids. If you do what we do in Orange, and some poor guy in a northern nursing station who's a 3.5-hour flight away from the trauma center has something bad happen to them, you may have no choice but to actually give more crystalloid because that's the only thing you have to try to at least maintain a basic perfusion pressure. So I remember going to a talk from a trauma surgeon originally from Texas, Ken Maddox, who's a bit of a guru of trauma, and I'll try to do this with the right accent. What he used to say is the only good thing about the ER is that it's on the way to the OR. So basically the idea is that, you know, if you've got a trauma and you've got a surgical source of bleeding, the most important thing to do is actually get him to the operating room and fix the problem. And so in his urban trauma system, they basically recommend getting the surgical situation ready, having the OR ready, and spending as little time as possible in the emergency department if you have a source of hemorrhagic shock that needs to be fixed. And certainly I'm not as an extreme believer in his idea. I certainly think there's a role for emergency departments for resuscitation, but I think the concept is important that you have to fix the source of bleeding right away, and that's better than giving more blood while you're waiting to get the patient to the OR. So quick pop quiz. The pH of normal saline, is it 7, 6.5, or 5.5? Now we have not set up a poll here, so I just want you to take a pause for 5 seconds. I want you to think about what you think the answer is, and so here's your 5 seconds of pause. All right, so we'll see if you're right. Oops, sorry. So pH of normal saline is actually 5.5. A lot of people don't realize that. So normal saline is very acidotic. So as a fluid for resuscitation, for trauma, or for hemorrhagic shock, I tend to go with other more physiologic-friendly solutions. Normal saline can cause worsening acidosis. There are other more physiological-friendly IV fluids like Ringer's lactate or Plasmolite, which have a more normal pH. And then if you're very acidotic and you have to correct what's already there in terms of acidosis, you can get sodium bicarbonate, and that can actually fix the problem. You can use that as a crystalloid bolus as well. Tranexamic acid is really important and increasingly being used in the pre-hospital setting. And what this basically does is it blocks the production of plasmin, and plasmin will break down your fibrin clots. And so there's good evidence that in patients with significant trauma, with hemorrhage, that if you give tranexamic acid in the first 3 hours after trauma, it reduces mortality. And this has been tested in multiple settings, including developing countries. And certainly, if you're in a situation where you don't readily have access to packed red blood cells, it's really important to try to stop the hemorrhage as much as you can. So this is a really important consideration for early tranexamic acid. So I'm going to stop there, and I'm going to turn it over to you, Wade.
Yeah, actually, Randy, if you just want to, you can pop it back a couple slides if you need to, but there was just a question that came across. It's probably as good as time as any to answer. It was just, the question was about the use of PCCs and vitamin K in consumptive coagulopathy. It might go a little bit beyond what we had anticipated for this discussion, but maybe you could answer it anyways. I'm sure somebody's interested.
Sorry, guys. Yeah, generally, you know, PCCs for the most part are reserved for patients as an antidote for Coumadin. So if you have a patient that you know is taking Coumadin, then you would typically use things like Octaplex to try to replace the clotting factors that are missing. We'll also use PCCs in patients on some of the new oral anticoagulants that don't have reversal agents. But for trauma, typically our choice would be fresh frozen plasma, and that sort of replaces all the factors that are missing. There are other clotting factor formulations that are being developed increasingly that don't rely on sort of a frozen liquid form because it takes time to thaw it and give it. So in the military, other organizations are looking at other sort of dried forms of clotting factors that you can give. The other substances you can give are cryoprecipitate. So that's used if your fibrinogen levels are very low. Cryoprecipitate can directly treat the fibrinogen lack. And so there's a whole big discussion on how you measure coagulopathy in trauma and severe trauma. You also in liver failure patients and other patient populations where you can actually look at which clotting factors are missing. And you can do that rapidly using things called TPG thromboelastograms and ROTAM, which are basically these sort of point-of-care tests where you can look and see, why is this patient coagulopathic? Do I need to give them fresh frozen plasma? Do I need to give them cryoprecipitate? Do I need to give them platelets, for example, or tranexamic acid? So some very cool technology that's available in a number of the major trauma centers that can actually tell you exactly what's wrong with the coagulation and give the right stuff. But things like PCC, for example, are not typically given for most trauma patients because there's other things. It only has a select number of clotting factors and it doesn't really replace what's missing.
Thanks, Randy. Okay, if you want to move forward, the next slide's mine, I guess. That'd be great. So tourniquets, right? So I've already said it. Tourniquets are awesome. Tourniquets are amazing. We've got the overwhelming evidence for tourniquet use in hemorrhage control in the military arena was done during the last Iraq War and Afghanistan. The numbers are overwhelming and the downside is quite low. When you apply these in the case of, so let's just step outside of the crush syndrome, let's just stick with hemorrhage control. As we've already mentioned, yeah, direct pressure is still a go-to. We know that pressure points does not help. But any time where we have uncontrolled hemorrhage that's not controlled by pressure, we're going to apply the one of these tourniquets, and hopefully you'll see them in your kit. If you don't already, hopefully you'll see them soon, and if you don't have them soon, maybe you should be pursuing that with your base hospital and your service to see if that's something that you can add to your kit. What we know about them as well is that when they're in place for upwards of 3 and 4 hours and even more, that transient palsies are the most common adverse effect. But these, even in cases, there's even some cases of upwards of 6 to 8 hours of tourniquet application with palsies that were, again, only transient. But what we do know is that, and then full function of the limbs are still exist as long as the limb, in the absence of having to amputate the limb, that would be. So these things work great. They're simple, they're user-friendly. If you have them, get them out and make sure you know how to apply them properly and know what equipment you're using. Next slide, please, Randy. So this is just talking a little bit about logistics. Now, you may or may not have been involved in on-scene responses with helicopter crews, our critical care teams from Orange, or in other places in the world where you may have been, but just tell you a little bit about how it works right now. So again, Randy's already mentioned is that blood product is what we want to be giving patients who have volume loss from hemorrhagic cause. Whenever there's blood loss, we want to replace it with blood, not with normal saline. It doesn't have the benefit. Normal saline or Ringer's lactate preferably are your go-tos to get yourself to a reasonable perfusion pressure, which we've already identified is actually quite a bit lower, and permissive hypotension is quite acceptable because of the downside of a lot of crystalloids. Randy's already nailed that, and hopefully you understand that very well by now. But blood products are really the way to go. So packed red blood cells is something that we don't currently carry on board the aircraft. We have to obtain it from hospitals, and that requires a little bit of logistical organizing through our transport medicine physician, who is on call and available either in our dispatch center or one of our bases. They might be at site. So in this particular case, what Dr. Wax had to do was make phone calls to the local hospital, and we'll get these blood products transported out to us. An ACP flight or a CCP flight within Orange has the ability to administer blood products, be they packed red blood cells, fresh frozen plasma, or platelets. Typically, packed red blood cells is most common. We would do pre-hospitally. I haven't had a case of administering anything else pre-hospitally, only inter-hospital. So what we'll do is we have these brought to us either by EMS or by police. We take uncross-matched O negative, or we can use O positive for males, but O negative for everyone, including women of childbearing age. And what you'll find, though, is the trend is towards helicopter EMS around the world is now carrying blood on board. Even within Canada here, STARS and BCAS are all they've all added this to their complement of equipment that they or of items that they have on board their helicopters, and it is very common around the world. We are probably going to be behind them, and we'll probably be in a situation of being able to do that in the near future, we hope. But in the meantime, we have to go through this process of having stuff brought to us. Administration of the blood products, again, requires the type of the qualification, as well as large bore IVs. And so ideally, again, large bore, just as a reminder, 16 or better, please, would be ideal in these cases. And or intraosseous as well, we can use without any problem. And they require a blood administration line and a 40 micron blood filter, which we also carry within our kit. So that is how that happens. It does happen, and it does happen rather regularly, and I think more so now as the evidence is overwhelming about how important it is to do a balanced transfusion and ensure that we are getting red blood cells into the patient, not just saline. Next slide, Randy. Which means I get a break because you're, oh, yeah, it's off to you then.
Okay, so thanks, Wade. So I just want to talk quickly about surgical amputation in the field and how this fits in. So during the workshop we did at the Ontario Paramedic Association conference, we actually brought in some pig legs, and we actually had people practice the skills of field amputation. So we can't do this virtually, but just to talk about the basic concept. So it's actually, you can do something really sophisticated, or you can do something really simple. And so sort of the simplest way of approaching this, all you really need to do a field amputation is a tourniquet to sort of help prevent bleeding from the limb that you're going to amputate. You need a scalpel so you can sort of cut through the soft tissues. And there's something called a giggly saw, which is basically a sharp wire. And basically all you do with the wire is once you cut down the soft tissue, you saw through the bone with the wire just going back and forth. It's kind of similar to what people will use to cut a tree. You think about sort of those little chain-type saws or so sharp saws that people will use as a band to chop down a tree. It's very similar. It's just a thin, sharp wire that can go through. It's very inexpensive, very easy to do. Trauma teams that are actually well organized to do this as a field amputation, many of them have a battery-powered saw. It's a little bit faster, a little bit cleaner. But the technology to use this is actually pretty minimal, and the skill of doing this isn't that hard. And we actually had multiple paramedics actually successfully amputating our poor pig. It was from the butcher. The pig was dead already. It was destined for the barbecue otherwise. But we were able to extricate the pig with the field surgical amputation. Paramedics learn the skill very quickly. I'm not saying that paramedics are ever going to be doing field amputations, but I'm just pointing out it's something that can be readily taught to anyone in theory, and certainly any physician. You can be taught the skill. The complicating thing is really the judgment of when to do it and how to get the resources there and the people there to actually do that. So the three situations when you potentially think about a field amputation would be you physically are never going to be able to extricate that patient. So let's say in this case, there's absolutely no way you could have gotten the part of the rock off this patient. It was never going to happen. And the only way to ever get this patient out is going to be able to do the amputation. Then you just have to do it. If the patient's too unstable to delay extrication and they're going to die if you just leave them there, then eventually you have to make the choice in the field to go ahead and amputate so you can expedite the extrication. The other situation as well, if you're in an unstable situation where there's a significant risk to the patient or the rescuers because of the actual environment of the scene, if you don't get that patient out fast, sometimes you have to make the decision to do a field amputation to expedite the removal for scene safety. So those are the three kind of main categories of situations where you think about a field amputation. And who can do that? So in an ideal world, in the situation where you need to do a field amputation, you get a trained EMS transport physician who's able to come on scene and actually do that. But the reality is, certainly in Ontario, it's not common where you're going to have somebody readily available who can do that, especially as you get more into rural areas. So you may have to rely on an emergency physician or a surgeon from the nearest hospital to do this. I can tell you right now, there are very few emergency physicians in the province who would feel comfortable doing a field amputation if required. Certainly the surgeons may be more comfortable with that, but people who don't regularly deal with trauma, for example, may not be familiar with the equipment or how to do it. So in an ideal world, you really want to make sure that people know how to use the equipment, have actually practiced with it, and have drilled in the pre-hospital environment to know how to do a field amputation so they can actually be comfortable. And I think really so that they know how to work with paramedics on scene to be able to do this effectively. Because as you can see from the pictures before, the team from Hamilton was showing up in scrubs and Crocs, and like the team were fantastically skilled medically, but they weren't really trained and experienced in working in a pre-hospital environment. So in an ideal world, you want people doing this who actually have worked in a pre-hospital environment and can do it safely. The other challenge is trying to get somebody to the scene in a timely manner. The logistics are very challenging if you don't organize this in advance. So kudos to the trauma team in Hamilton that they were able to get out there quickly enough to be available to do it. But the reality is that many, not certainly rural areas, but also urban areas, if it's not practiced and organized and a clear protocol on how to do this, the likelihood of getting a team out there in a timely manner with the right equipment, very challenging. And I think it's something that needs to be thought about in advance to practice. And yeah, so here you can see at the scene, here's all the guys in their scrub suits, and somebody I think is wearing some boots, and I think there's some Crocs and some other things. So probably suboptimal environmental protection with the clothes that the hospital team was wearing. But still, certainly, I'm sure everybody's glad they showed up and they made a big difference in this situation. As well as a picture of Dr. Sawatsky, one of our medical directors at Orange, and it just so happened we had him on board one of the helicopters, one of the two Toronto helicopters, and we actually tried to get Dr. Sawatsky to get on scene. He's actually practiced before, because we have practiced with our group doing field amputation, and he would have been able to potentially assist with on-scene medical direction to help out. Unfortunately, due to mechanical issues with the helicopter, there was a bit of a delay getting out, and he was arriving on scene just shortly after the patient was extricated and ready to go. So I don't think they haven't landed. But that just goes to show you, even with a medical director already with a helicopter crew, we still weren't able to get a doctor there through our transport service on time. We had to rely really on the local hospital to be able to provide the service to do this. So I think we have a lot of thinking to do about the logistics and how we approach this from a systems perspective. Wade, I'm going to turn this part over to you.
Right, thanks. There was actually, I'm just going to answer a question there that was asked, which was about TXA, just before I finish up this part. The question was basically, do we think that TXA should be available sort of widely within pre-hospital in Ontario? And it's purely I guess an opinion, but I think it would be mine that I think I would like to see. I think the evidence is quite overwhelming, the value of TXA and the ease of administration, the relatively low profile of adverse effects when it's administered sooner than later. And when you think about it, if we've got this 3-hour window, certainly we have opportunities within our environment, within the province of Ontario, that there would be lots of services with longer transport times where their ability to administer TXA would be essential to get it within that window of time. It's a relatively easy drug to administer. As I say, not a lot of big adverse effects. You need intravenous access. And so anyone who's able to perform intravenous access, I think it's a relatively safe drug to be to be for them to be using at any level of care. That's my personal opinion. I think the evidence is very strong for it. So that would be my answer to that. I hope that helps whoever had that question. And I guess just to sort of finish this off so that we have a little bit of time for some questions here. We got about 23 minutes left on the clock. You know, it's a huge team effort. There's no question. I've just identified on this slide here some of the groups that were involved in this. I remember at one point in time turning around and realizing how many people were there involved in this effort, or there to back up, or there to help out in whatever way they possibly could, and it was quite astounding. From first medics on scene who stayed there through the whole thing and worked themselves silly, and local fire rescue who dealt with a very difficult extrication, which is not common, as well as we mentioned the trauma team who arrived and really worked in concert with us, looked to our expertise as pre-hospital experts, and they asked us about what we needed to do or how we could do it. They listened to us. We listened to them. It was a very strong team effort. It was really it's always quite rewarding to see and experience that when we all do come together to get a job done. And this is a rather dramatic case, but I think it's something that I think we do it on a relatively daily basis, and makes us sort of proud for the work that we do, and shows us what is possible when we all take our little expertise and put it together to work. I think it's very rewarding. A couple of points about just some sort of human factors through this. It's already been mentioned that this was physically a very difficult experience, in that it's the physical taxation on each one of us there was quite dramatic, and it's for a prolonged period of time. So you can imagine sitting for almost 2 hours under the beating sun, and I have no idea how much fluid I lost personally, or anybody else, in bunker gear and everything, and helmets and so on. What we did have was we had on-site a command who was there to somehow get us fluids and ensure that we were looked after. I made a note of the one moment where my partner looked to me and said to me, "You need to get out of there and you need to take a minute away," where I refused, because, you know, that's how we are as medics, right? We're not going to leave. We're going to stay there until it's done. And however smart as she was, she insisted, and she said, "You're going to get out of there," and I was immediately rehydrated. And that's all part of looking out for each other in these particularly difficult things, the difficult responses we go to. And they don't have to be as dramatic as this, but they are something that we deal with every single day. And to be watching for your colleagues and be watching for those signs of stress, to be watching for stress like after the event, to be even looking for signs of acute stress disorder, to be thinking about, are you going to do a critical stress debriefing afterwards? I think we can't have this discussion about this and just focus on the medical, that we have to think about how we look after ourselves as well, because we're absolutely no good to anybody if we're not managing our own needs as well. And I can tell you that at the end of this response, that literally physical exhaustion, my partner and I just sat down on the floor in the hallway, in the OR hallway, and we were physically, emotionally, and mentally just completely exhausted. The response to this from our organization was to hear what we were saying and let us return to base and do all of our appropriate decontamination. And then we were fortunate enough to have within our system a master social worker, Tom Walker, who you may have read his articles through different pre-hospital literature and magazines, and we were fortunate enough that he's able to either, in this particular case, was able to come physically to us and help us and have a debriefing, which we wanted, and which was so helpful and so valuable that the next day I felt like I was still sort of a whole person. And I think it was not lost on me that how good I felt despite the stresses that we had been through. because of that ability to have someone there to help you out with that. So if you don't already have a peer support, or if you don't already have someone that you guys can contact in these types of difficulties, then I think, you know, it's something that I'd like to see everybody continue to push for within their own services. And nice to have so many people looking out for us at the end of this and help us get through the stress of all of that. And I think there's actually just a little question that just popped up from Steph here, and I'd like to answer that right now. She just asked about how the patient fared, and I thought, and of course the beautiful thing about this, and the one thing that makes it a lot easier to get through the intense emotional stress of the call and mental stress of the call, is the fact that this patient fared very well. He is alive today. He lost part of one leg, was surgically amputated the following day. He did very well. It required a lot of rehabilitation, a lot of work, but he did very well, and in fact to this day he is doing well, to the point that he does have other medical concerns, and he was actually medevaced by Orange from his hometown in Northern Ontario down to Southern Ontario just recently. And we got word through one of our colleagues that he was quite thankful for all the work that everyone had done, and he was really overwhelmed when he talked about it, is the way it was described to us. So he is alive, and you know, short a little bit of short part of one limb, but I think that he seems to be quite okay with that, for the fact that he does get to continue living. And so yeah, very proud of the work. And I don't have anything else, I think, to add there. Randy, did you have anything else?
Sorry about that, getting some echo. I just have a couple other quick slides I just wanted to show, and then we'll definitely we can start bringing in the questions as well. And I'm just going to take advantage of this opportunity to talk about how this really can fit together for everybody. And so we know in the audience there are paramedics at different levels of certification. And I just wanted to sort of go over you know, what it is that you could potentially do, and hopefully take something out of this talk and apply it if you're ever faced with a situation like this. So, oops, sorry. So if you think about it from a PCP perspective, you know, what are the things that we could actually do that are within your scope of practice? So certainly, if you're faced with a patient like this, you know, applying tourniquets is something that you could potentially do. If you are in a service where you've got a PCP Plus who's able to get IV access, that's great. But other things, if you're thinking about it, if you've got the patient on a cardiac monitor and the patient's getting hyperkalemic, you actually even have some things in your kit that you can actually use to treat with for hyperkalemia. So for example, Ventolin does a very good job of shifting potassium, and in theory epinephrine can do that too. So even if you can't give IV epi, you've got IM epi. So certainly doing things a little bit out of the box, you know, requires medical direction if it's not part of your standing orders medical directives, but there are some things as a PCP you can do, and certainly as an ACP land, a little bit more access to things, IV fluids, potentially bicarbonate, calcium, other things that you can do to try to treat these patients. And certainly as we move on to ACP flight and critical care flight, you know, the options for treating this kind of patient are certainly open and wide. But the fact is there are lots of things that all of us can do, regardless of whether we're physician or paramedic, and regardless of your level of certification as a paramedic. It's important to, first of all, recognize crush syndrome, be aware of the problems. Actually, the paramedic from Hamilton who was there, one of the most important things she did out of all of this is take some medical control of the scene and ideally prevent the rapid extrication of this patient without a controlled plan to manage the medical issues with the potential crush syndrome and the release. So you know, we're grateful for that recognition, and so hopefully everybody can think about the different interventions and medical considerations, and think about what you can do with your scope of practice to potentially help a patient and work together. And so if you're the PCP who's first on scene and you're waiting for the helicopter to come, there are definitely things that you can do to try to help these patients and work alongside our flight paramedics to optimally manage the patient. So this was definitely a team effort all around. The last thing I just wanted to do is just show a couple of quick slides, if you don't mind. And one of the things that I really thought about in this case is really how, as physicians, we can support people a little bit better. And I have to be honest, Wade and Tara were on the scene. I'm talking to them by phone. I'm sitting in our operations center in Toronto, and my chair was comfortable and the air conditioning was on. So certainly I was nowhere near as exposed as these two paramedics and the other first responders on scene. Were in a very difficult environment, and I was thinking to myself as a physician, how could we help out a little bit better, and were there better opportunities for us, or can we look at the system and think about as physicians how we can help out in the pre-hospital setting a little bit more. It's maybe a little controversial. I just want to throw this out here. I'd be interested in comments. But just a reminder for medical direction, in this case, Wade and Tara had a number of standing orders and medical directives, and as critical care paramedics, they actually have a lot of options in terms of initiating treatment, even if they can't reach the transport physician up front, and many of you have that as well within your scope of practice. And then recognizing in this case we had to use the sat phone for online medical direction. We tried to get Dr. Sawatsky to provide on-site response, which just didn't work out, but we did have the surgical team from Hamilton, and so it was fortunate that we had an enhanced scope of practice beyond what the paramedics could do, because we actually had the surgeons on scene to work alongside with Wade and Tara and the other people there. And so where do physicians really fit in the field? There's the whole idea of the concern in Europe about stay and play. If you get physicians actually showing up, first of all, if it's a dermatologist, they may not be particularly helpful at all. But even for people who are trained in trauma and EMS, do they end up keeping patients on scene longer than they need to? Or do you just ignore the fact that physicians might have a role in the field, or any of us for trauma, and you just load and go and just get out of there and get to the emergency department as quickly as you can? And that's oftentimes the most appropriate thing to do. But there may be an opportunity to think about load and play, which is sort of a hybrid all of this. Is there a way that physicians can potentially help paramedics in the field for cases like this that are uncommon, but the ability to have physicians there who can do something that isn't within paramedic scope of practice, there may be a role for that, and thinking about how that fits. And there's a lot of barriers to actually doing this. There's having physicians available, actually training physicians to do this in the field, the expense of having physicians available, and the equipment response logistics are all barriers to regularly having availability of physicians in the field. And so really in this case, I know Hamilton's been thinking about this, and I think other jurisdictions as well. Is there a better way to organize the ability to get physicians out there in these rare situations so that they can actually help paramedics and provide an additional level of care that you're forced to do because the patient's trapped and you're stuck on scene for a long time? In general, I'm not advocating at all that physicians should be, for example, regularly on aircraft or ambulances, or that physicians in the field is a regular thing, is because paramedics in Ontario can provide incredible care to almost all patients, and this is something that's really an evolution. In other jurisdictions, they're trying to figure out where physicians fit in. And so just to put things in perspective, to think ahead, things like RABOA, which is basically the idea of putting a balloon actually up into the aorta, so if you have a pelvic fracture and you're exsanguinating, physicians who can actually do this in the field, inflate a balloon, stop the flow. It's almost like an internal tourniquet, and prevent patients from exsanguinating from pelvic fracture. Good case reports of this being done in jurisdictions like the UK and London. Field thoracotomy, rare indications for it, but definitely documented saves. Does it justify having physicians in the field all the time? Absolutely not, but there's some situations where something like this might have saved people, and there's documented saves. Or the most extreme is doing ECMO in the supermarket for cardiac arrest, which they've occasionally done in Paris. It's kind of a classic picture that's been shown at the supermarket. There's also another one for field ECMO in the Louvre for patients with refractory cardiac arrest. So there's definitely huge extremes in all of this, but just something to think about, that in certain jurisdictions, there's a better organized way to get physicians out in the field, not showing up in scrub suits and Crocs, but actually people who are properly trained who can actually help and augment the care, not replace the care of paramedics, but in those circumstances where it's really justified, augmenting the care. And so just throw that out there just for thought, because I think as things are evolving in other jurisdictions, I think physicians, our role, we may be falling a little bit behind in figuring out how to help you guys in the field for these unusual and infrequent calls, but situations where our input and our help might actually save some more lives. So I don't know where we're going with all of this, but I wanted to take opportunity to sort of throw out this as sort of an editorial comment and be curious to see people's perspectives on that as well. Okay, so I'm going to stop there actually, and we'll be open for questions.
Great, thanks, Randy. It's Steph again. Fantastic presentation, and other than a number of pats on the backs and well done's coming through from our audience, I do have one question left. And I think it's probably more so directed at Wade. So Wade, earlier you talked about the challenges with inserting the pillows or the pillows underneath the slab, and that the ground was too loose and you weren't able to secure them. The question is regarding the crane that arrived. So what direction or instructions did you guys use to ensure safety of everyone on site when the crane did arrive?
Okay, thanks. I think the way that this had happened was, again, with the rescue and the lifting of the block, it really does fall to the fire rescue on scene. So the captain in charge at the scene made all arrangements for that. At any point in time when there was an effort to move the object, basically the area had to be cleared. And typically one firefighter, this is their control, so one firefighter would stay with the patient essentially, and we would move a few feet away so that if anything went sideways, that we didn't have multiple casualties amongst the rescuers. That's basically how that went, and when the object was finally ready to be lifted, it was lifted, and it was, the minute it was lifted, the patient was pulled onto the scoop stretcher, and then we were out of the and moved out of the way of the wall.
Great, thanks, Wade. Another one has come through. The question is regarding wound packing. So in this case, once the wall had been moved, was there any need for wound packing, or what would you suggest in that case?
So this is Wade. We didn't have to do any wound packing. So the picture, I'm trying to paint a picture of what the limbs looked like when they came out. You could see that there was obvious femur fracture on the one side. There was tib fib on both, and then there was several open wounds. The bleeding, however, with a significant amount of adipose tendons and muscle tissue extruded from the sites. We did just do a straight pressure dressing, which didn't require any pressure, so we didn't actually have to pack any of the wounds, and the bleeding was controlled without any difficulty.
Fantastic, thank you. Is there anybody else who would like to add anything to the presentation? No. Okay. Huge thank you again.
A quick question actually for Dr. Luell, who's on still. Mike, any thoughts or comments about response in your jurisdiction about what would you guys do, or how would you handle this if this happened for a physician response in the London area?
Great, thank you, Randy. Can you hear us okay?
Yep.
Great. So we've had a lot of talk about this actually following your presentation at the OPA conference, and really at this point we don't have a mobile team out of LHSC to respond for local things, and then also as you go to smaller centers with less human resources around, not in terms of ability, but just in terms of number of physicians around, there's also less capacity as well. So therefore, it also speaks to just what would happen if these rare events happen in our local area. I was speaking to some of our trauma team folks as well in relation to this, and there's certainly an appetite to explore developing such a team to respond similar to Hamilton, and I think that's definitely in the works for the future. I know that we used to have, as you recall, Randy, the transport positions had the capacity to respond as part of the orange response, but nevertheless that was very hit or miss given the fact that the way the call is structured, we do call around the province, and it would have to have the perfect storm to have the guy on call or the person on call have the accident happen just in that same area. So therefore, that was disbanded. So I think this sort of speaks to a need to be able to have a capacity to respond to low frequency scenarios such as this.
And just to comment, so one thing that I just kind of skip by this slide, but we are learning interesting lessons from other jurisdictions. And so, for example, in the UK, even in the more rural areas, they actually do provide a very basic, what they call immediate care training course to physicians to specifically train them how to provide care in the field. And they actually provide care in their sort of regions on a 24/7 volunteer basis. And so it's difficult because the healthcare system, there's not a lot of money to go around for a lot of things, but certainly in rural areas in the UK, they felt this is so important that groups of physicians have actually taken special training and in an integrated way with the system. They don't replace paramedics in any way, shape, or form, but are actually there to help paramedics in certain situations on a volunteer basis. So I don't know where we can go with this in Ontario, but it is a huge challenge to the geography and, to be honest, the lack of training of most physicians to practice in this area. So I don't have an easy answer for most jurisdictions, Mike, but I'm glad you guys are sort of thinking about it a little bit more.
Yeah, for sure. And I think one of the things that you hit on, the point exactly I was going to make, is the fact that having been physicians that I've spent years doing ride-alongs both on land as well as air, and I know you can speak to this as well, Randy, for your experience, but you realize just how specialized our paramedics are in these environments. So we show up there and we have maybe the content knowledge, but we don't necessarily have the actual practical ability to even do some of the most simple things. And so you realize how highly skilled our paramedics are in the front lines, being able to access the tools of the trade so easily. So when we're in our trauma room in our emerge, we know where everything is and we feel quite adept at that. You put us in that transport environment or you put us on the scene environment, it's a very, very different world. So definitely kudos to our paramedics. They're certainly highly trained and very specialized in what they do.
Great. So thank you again to Randy and Wade. I don't have any other questions, so we will close out. Thanks again not only for sharing your presentation, but definitely your experiences on this call. I think everyone who's watched this has definitely come out with some very valuable knowledge. So once again, thank you very much, and have a great afternoon, everyone.
Thanks.
Thank you.
Thanks very much, guys.